Good evening and welcome to Wednesday 8:30, and this is the Cancer Academy time. And we are moving ahead with our esophagus series in the month of February. And this time we will be focusing on esophagus. Today we are having a surgical topic followed by a debate on the neoadjuvant therapy for operable for locally advanced CA esophagus, which will be followed up by a lecture on the radiation planning for esophagus. And I hope we will be able to answer a lot of the usual questions which are associated with management of non-metastatic esophagus that we come across. Why we thought that esophagus is important to talk about and discuss is that esophagus is not a very straightforward topic, and you will be really surprised that it is the fifth most common cancer amongst men in India. Even I was shocked that this was such figures, but I had a chance to go through the projected numbers from Globocan 2020, which were released in January this year, and after stomach, it is apparently esophagus, and which gives us really a good food for thought that why is it so, and how do we need to improve our management, because our survival figures are dismal at best to say. To talk on the surgical part of it, we have a really good friend and a really skilled surgeon to talk about it. And before I introduce him, I'll actually introduce our moderator, who is Dr. Shubham Jain. Dr. Shubham.
It would really be a pleasure to hear Dr. Prashant Penumadu touch upon all these aspects, and I welcome him and request him to start with this presentation.
Yeah. Thank you very much, Dr. Shubham Garg and Shubham Jain. And I think Shubham has really made me look like a villain. And you can safely come down to Pondi. Pondi is a beautiful place, trust me. Not wasting much time. I think we'll have a lot of questions. I think it would be better to discuss a few things, and then I would also cover a few things on when it comes to the slides part of it. So I've tried and kept it simple, Shubham. Can you see my slides?
Yes, yes, they are visible and you're audible. Yes.
Okay, great. I think that's the most difficult thing. So, yeah. So the main objectives and goals, like at the end of the talk, I think you should be able to know what are the three components of esophagectomy. You should be able to answer. And I hope all of them are students, so I've tried and kept it as simple as possible, but also touching a little bit of evidence, because without evidence, eminence-based medicine no longer is good, and evidence-based medicine always prevails. So the different approaches, either VATS, open or robotic, which is better, and what exactly, different types of substitutes, what type of surgery, and to answer at least a few of these questions, if not everything. Now we divide esophageal cancers into two types, mainly the early and the locally advanced esophageal cancer. The early esophageal cancer are those confined to do not reach the surgeons, and unfortunately we do not see these cancers. We have two options, either the endoscopic mucosal resection or the endoscopic submucosal dissection. So these are some of the indications that wherein you do an endoscopic mucosal or an endoscopic submucosal dissection in very early T1A, M1, M2, or less than 2 centimeters, or elderly with multiple comorbidities or sometimes patient preference, and submucosal dissection in M2 or SM1 lesions without any evidence of lymph node spread by proper adequate imaging techniques. And then next, anything more than this needs surgery. T2, N0 goes in for upfront surgery, but otherwise I think the locally advanced is a neoadjuvant chemo versus neoadjuvant chemo radiotherapy, which I think there is an excellent debate by two wonderful speakers, and which will be discussed more in the debate and we could know. So both are standards of care or not, but for locally advanced, one of these modalities should be used. Now coming on to the extent of surgery, as Dr. Shubham rightly said, it is important to know the extent of surgery, because the most important is the lymph node involvement and the lymph node spread. you need to understand the pathology of the lymphatic spread, which makes you take a decision whether to operate and the extent and the mode of surgery. So generally there are three pathways. One is a longitudinal spread, which goes along the submucosal, the transverse spread, and then which penetrates through the muscularis mucosa into the thoracic duct and the venous system. So this is where, whether you should take the thoracic duct or not, whether you should ligate the esophagus or not. I have not put on slides for this, but we would discuss one by one issue for these things. So can we predict lymph node metastasis? Yes. The reason for doing a lymph node dissection in anything beyond T1 is because the incidence of lymph node metastasis varies from 30% to close to 80%. And as the stage goes up, it is much higher, and henceforth lymphadenectomy should be a part and parcel of your surgical management. So which are the high risk? As I said, poorly differentiated lymphovascular emboli. If you have an infiltrating growth pattern, these are some of the risk factors which actually predict a lymph node metastasis. Now, which groups of lymph nodes are involved? You know that there is a possibility that of lymph node metastasis based on stage, but does tumor location make a difference? Yes. The upper third generally spreads to the upper mediastinal or the cervical nodes. The middle third can either spread upper, middle, perigastric or the periesophageal, but lower third perigastric is the most common. And does the pattern change based on the pathology? Yes, squamous and adenocarcinoma also has a different spread pattern. So for the interest of residents, there are two large retrospective series which you should all read. Showing the extent of lymph node involvement according to the location of the tumor in terms of upper, mid, lower third, wherein this, if you see, surprisingly, the supraclavicular lymph node involvement is quite significant, even in the middle third. So that is the reason why whether you need to do a 2-field or an extended 2-field or a 3-field, which we will be coming to these terminologies in the next few slides. So this is an interesting paper, and this is another interesting retrospective series, which also gives you a broad picture on what the extent of lymph node involvement depending upon the location of the tumor. So I think residents should all read up this, and it is very important to understand the anatomy. So now coming to the adenocarcinoma, as I said, or the squamous cell, the pathology also makes a lot of difference, because generally adenocarcinomas are located in the lower third or the gastroesophageal junction, and the lymph node involvement predominantly is in the perigastric or maximum up to the infratracheal region. So that is the standard 2-field, and henceforth the surgical approach would vary. But if you have a mid-third squamous, more likely that you will have the upper mediastinal nodal involvement or even the cervical nodal involvement, which can be as high as 22% depending upon the proximity of the tumor. So these are different lymph nodes. We'll not get into the details of it. And if you are operating on esophagus or stomach, everyone should read the Japanese guidelines, and which will actually, without which any reading for esophageal cancer or gastric cancer is incomplete. So these are some of the pictures taken from the Japanese guidelines 2019, that is 11th edition. Here, as you see, the lymph node involvement are grouped into 4 stages. So you have a group 1, which is the pink ones, the blue ones are group 2, group 3 are C, and then the white ones are the group 4. So depending on the location, they have divided them into N1, N2, N3, N0, N1, N2, and N3. So based on this, the extent of disease can be. So for a lower third lesion, if you have a supraclavicular lymph node involvement, I'm sure, so it's not worth operating these group of patients. So it is important to understand and read your imaging well and know the level of lymph node involvement before you embark on your treatment plan. So these are some of the other pictures which located in the lower third as well as the gastroesophageal junction. So it may not be possible to cover each and every station, but just to put it through a few definitions before we get on to actually lymph node dissection. So the commonly used lymph node dissections is by International Society of Disease of Esophagus. So we broadly divide them into 3 categories. So they have 4 categories here, but I would broadly divide them into 3 categories. One is the standard 2-field. So when you say a 2-field lymphadenectomy, it's a standard 2-field lymphadenectomy. So this is from the diaphragm up to the subcarinal nodes in the intrathoracic part of the lymph node dissection is being cleared, and also the most important ioto-pulmonary window. Along with this, almost always you add on the abdominal part of the lymph node groups, which includes the D1 plus or the standard D2, so-called classical standard D2. Now you have extended two field or the total mediastinum. So I would put total two field or an extended two field into one group, wherein when you clear the right paratracheal gutter, that is nodes along the right paratracheal region and the right recurrent, you call it as an extended or a total mediastinum when you also involve the left paratracheal gutter, including the nodes along the left recurrent laryngeal nerve. So the most commonly done an total mediastinum is generally for mid-third esophagus, where you would prefer to do a total mediastinum in these group of lymph nodes. In addition to this, if you get onto the cervical lymph nodes, which includes bilateral paraesophageal, that is nodes lateral to the carotid vessels, as well as the supraclavicular, these group of nodes make it the three field. Why should we have different fields of lymphadenectomy, and why one is followed over the other? Because it is the morbidity associated with lymph node dissection that makes us choose the extent of lymphadenectomy, but not to compromise on the oncological principles and safety. So in picture, as you can see, the first picture shows a standard lymph node dissection, which is up to the esophagus and the AP window, total mediastinum. And when you do a three field, you have the 104, 101 left and right, in addition to your total mediastinal lymph nodes, that is the standard three field lymph node dissection. So the common morbidities that are associated with the three field in addition to two field is probably the dissection along the recurrent laryngeal nerves, which can cause temporary or permanent recurrent laryngeal nerve palsy, and which can be debilitating in the postoperative period. That's the most common complication which we generally see. And also denuding the complete trachea can sometimes cause tracheal injuries or delayed tracheal necrosis, though it is very rare and should not happen. So coming on to the approaches, apart from open minimal invasive, that is VATS or robotic, you need to know that it can be either be a transhiatal or a transthoracic or a thoraco-abdominal approach. So transhiatal and transthoracic is another matter of debate, and we leave it to the center of expertise, because the trials have shown equipoise. The meta-analysis have shown equipoise in terms of survival, but proponents and opponents of transhiatal and transesophagus still continue to debate. So transthoracic, you have two different types of transthoracic esophagectomy. One is a Mekion, which is the three incision. You have an incision on the abdomen, you have an incision on the thorax, and you have an anastomosis in the neck. So you have an incision on the neck. And Ivor-Lewis is a two incision technique, abdomen and thorax, and the anastomosis is in the thorax. The most commonly preferred, at least in our continent, is an Mekion esophagectomy. But if you see in the West, Ivor-Lewis is most commonly preferred. The main reason being the pathology. Adenocarcinomas are more commonly seen in the West, and so they most commonly prefer to do an Ivor-Lewis, whereas we do see a lot of squamous cell carcinomas where to get an adequate margin of around 5 to 10 centimeters, most of the times anastomosis gets into the neck. And another thing, it's also safer if you have a leak in the neck. And thoracoabdominal, very limited indications for thoracoabdominal, where you have a classical typical GE junction Sieverts type 2 or type 3 lesions. These are the indications where you would do a left thoracoabdominal approach. So as you know, transhiatal, there is no incision on the chest. Entirely surgery is done on the abdomen and anastomosis is done in the neck. The lymph node yield is obviously going to be less. So the proponents of transthoracic say it's a better exposure, you have better vision, better lymph node dissection, you can see and make sure that you're avoiding injury to important structures like tracheobronchial tree and the thoracic duct. Whereas THE, they say that there is no survival advantage of TTE, pain is reduced, pulmonary complications are minimal, less operative time, and so this makes them patients recover. And when there is no advantage, why should you go in and do a transthoracic esophagectomy? So this debate continues till evidence comes. So these are some of the trials. If you would like to go large trials between transthoracic and transhiatal esophagectomy, and the 4 randomized control trials with the meta-analysis also shows that of equipoise in these 2 groups. But however, the proponents of transthoracic esophagectomy shows that there is a 14% overall survival advantage, though this was not statistically significant. And patients who had positive nodes, probably the 5-year survival advantage was an additional 20% and 41%. So I think definitely those who have positive nodes, the clearance would be better, and likely that they are likely to do better with the transthoracic esophagectomy. So as I said, the evidence for 3-field lymphadenectomy is mostly comes from a retrospective series, and randomized control trials are going on. I think probably in a couple of years, we would at least get the initial results of randomized control trial. As I said, the morbidity and mortality is relatively higher in the 3-field group when compared to the 2-field group. And that is the reason why whether you should do a 3-field or whether you should do a 2-field still is a matter of debate, and evidence still does not exist. Now coming on to open or minimal invasive. Either of the procedures, whether you would like to do a transhiatal, transthoracic, Mekion or River-Lewis, can be done by any of these approaches. And the radicality of surgery should not change just because of the approach to esophagectomy, whether it is an open, thoracoscopic or robotic. So that is the most important thing. And so we have a few data, some data coming up comparing robotic minimal invasive versus open, which shows that the short-term and long-term outcomes were similar to in both the groups. But however, it is obvious that the minimal invasive esophagectomy is likely to be associated with a lesser complications, early recovery because of less postoperative pain. And probably most of the centers prefer to do minimal invasive wherever feasible, because the recovery rates are fantastic when compared to open. Pulmonary complications, especially with open, are much higher when compared to the minimal invasive esophagectomy group. So this is another trial which is recruiting patients as of now, and probably we will get between the conventional minimal invasive versus the robotic assisted esophagectomy, whether robot has an additional advantage over and above the minimal invasive. So the meta-analysis and systemic review also shows few case control trials. As you showed, there's no statistically significant difference between the 2 groups, whether it is robotic or a minimal invasive, in terms of morbidity, mortality, lymph nodes harvested, length of hospital stay. So, but as I said, the randomized control trial will give us more details regarding the same. Now, coming to the conduits, which is the best conduit? Now we have covered about the extent of lymphadenectomy. We have covered whether it should be an open approach or whether it should be a minimal invasive approach, and what are the conduits that are most commonly used. The most commonly used conduits are either a stomach, colon, or a jejunum. 99% of the times, I think stomach is the most preferred choice, unless and until you plan to do a total gastrectomy for these group of patients, wherein then the next best choice would be a colon. Jejunum is very rarely used. Only when the first 2 options are not there, you could still use a jejunum. But however, jejunum has been the choice for an esophagojejunostomy after a total gastrectomy with a lower esophagectomy, where the jejunum can reach almost up to the caninal region based on the 4th arcade. So that is another choice. Instead of pulling the colon through, it would be better sometimes to pull in the jejunum and then do an anastomosis. The most common route advantages, stomach is definitely obviously the best choice. Stomach can reach the tube, once you make the tube, the stomach can reach into the neck easily without any tension. And mind you, the gastroepiploic arcade, once you preserve it, I think probably the robust blood supply is stomach and that rather than anything else. The route of the conduit, most commonly posterior, almost always, unless and until there are contraindications. Substernal routes or the subcutaneous routes, which are no longer used. Substernal routes are mainly used for benign cases, wherein you have corrosive esophageal strictures, where you don't have an option, you try and use the substernal route. The shortest route is the posterior route. posterior mediastinum, and that's the best route. Substernal should be used only in oncological. If you ask me, where would you use a substernal? Probably when you have an R0, R plus resection, gross residual disease, and that's the only indication where you would use substernal, but otherwise, no, you wouldn't use. Why are we talking about the conduits? Because the most common complication for morbidity as well as mortality is the anastomotic leak. And as I said, most common causes, 90% is the anastomotic leak, which leads to morbidity or mortality after the esophageal surgery. So how should you prevent the anastomotic leak, which, as I said, is one of the most common techniques? So you can either use, there are different techniques for anastomosis. Most commonly used are a hand-sewn anastomosis, or a combination of hand-sewn and stapler, or a stapled anastomosis, or either using a linear stapler or a circular stapler, depending on what exactly you're using, or it can be either an end-to-end or an end-to-side. I would say that choice of one technique is not better over the other. Everything has got its own advantages and disadvantages. My suggestion would be to follow the similar kind of anastomotic technique based on your preference, on your expertise and your center, rather than just review of evidence. That would give you better results if you follow the same technique rather than keep changing the anastomotic technique for every alternate patient. So these are the most commonly preferred anastomotic techniques for an Ivor Lewis is generally either an end-to-end or a side-to-side, either a circular stapler or a linear stapler. I'll try and show you in one of the next videos how do we go about, or you can use the, as I said, in the hand-sewn, it can be either a single layer or a double layer. My choice is a single layer interrupted anastomosis. But sometimes I also, when you have good length of both stomach as well as the esophagus to anastomose, I would prefer a tri-stapling triangulation technique, which actually helps in preventing the strictures and delayed strictures, which is another common problem in post-esophagectomy in the post-operative period. So yeah, I'll just share the screen. So before we go on to during the video, we will discuss about end block resection, whether there is an advantage, or taking the esophagus is an advantage, use of pyloromyotomy, yes or no, whether it does. So I'm just switching over screen. So if there are any further questions till I change the screen, Shubham, please, you could just go ahead and discuss till that time. Shubham, are you able to see the video, Shubham?
No, Prashant, we are able to see the screen, but not the video.
Okay, just a second. I think I need to reshare the screen. Yeah, is it okay now?
Yes, it is now visible, yes.
Okay. Yeah, so I'll be showing an Ivor Lewis. So we have a circumferential lower third esophageal growth, as you can see on these scans. So the lower third, this is post-neoadjuvant squamous cell carcinoma, post-neoadjuvant chemoradiotherapy, and received, sorry. So in a robotic, the port position is slightly different depending on the robo you have, whether it is an XI or an SI. These ports are more or less the straight ports, which you tend to place in an XI, and this is how. So in an Ivor Lewis, the surgery always starts from the abdominal portion with mobilization of the gastric conduit. And you could either do it complete total laparoscopic or using a hybrid technique wherein you open and then do it. I generally follow the hybrid technique wherein you can divide the proximal part of the esophagus and then do it the thoracic portion. So the gastric mobilization, as I said, take all precautions. The gastroepiploic vessel is your dear friend, and try not to damage it at any point. So try not holding the vessel, stay at least about 1 to 2 centimeters away from the gastroepiploic, so that even the electrocautery, which is very close, can sometimes cause significant damage. to the arcade. And once the arcade is damaged, it would be very difficult. So as Oringer said, you should be able to see the stomach, which is pink in the abdomen, and as it reaches the neck, it should still remain pink. Then probably your chances of morbidity or gastric complications are less. So as you can see, the gastric mobilization, once you've done with the gastric mobilization, the tip and technique here is for gastric mobilization is try and mobilize as much as possible. Cauterization may not be required, but in case if you feel that the gastric tube is thin, then definitely you should cauterize so that that will give you adequate length. So here you finish on the greater curvature to the lesser curvature. I think there are a lot of non-surgeons too, I believe, right?
Yes, actually.
Yeah. So I'll try to show a little bit important steps I know. So this is the D2 part of the lymphadenectomy, retracting the pancreas. That's the left gastric vein. So nodes along the left gastric. So as you go the D2, so that is the left gastric, and then you try and do the entire lymphadenectomy all along the D2. So that is along the diaphragm. So this is the dissection of the nodes along the splenic vessel. So as you can see the splenic artery nicely. So you try and dissect the entire D2 group of lymph nodes. Then once you finish this, that's the hiatal dissection. So I've gone into the right thorax, opened the right pleura. You can see the descending aorta there. And with this, actually, you can reach almost till the till the carina easily through the transhiatal. Do the dissection as much as possible. I would prefer to do the dissection as much as possible. So both the pleura are open, and then the anteriorly along the periesophageal group of nodes, take down the entire groups of So then now you get into the thorax. And what I do is I commonly do an hybrid procedure wherein I staple off the upper end of the esophagus and then form a gastric tube outside. So these are the vagal branches, as you can see. So that's the lymph node dissection. So you can see the esophagus nicely. The lymphatic duct, I don't do an en bloc resection. As I said, so en bloc resection does not add on to any increased survival when compared to the non-en bloc, that is, you don't need to take the complete. So this, you can see the remnant stomach tube. So this is what I do. I leave that in the thorax and then come forward. So that is the esophagus. I almost always clip the esophagus majority of the times just for the ease. And I agree whether you should do or not, whether it causes, I would prefer just to get an adequate good esophageal clearance, nodal clearance. That's the only reason, but otherwise you need not do it routinely. So try and mobilize the esophagus well so that you can see the right recurrent group of lymph nodes there. As I said, it is important to do the right recurrent group of lymph nodes. Never use your electrocautery there. Try and keep your scissors a sharp dissection. You can, so that's a recurrent laryngeal nerve, which is looping around the subclavian vessels. And then you also do the left recurrent as well as this is a subcarinal group of lymph nodes, which is coming across. And then that's the AP and the left recurrent. So retract the trachea. You can see the left recurrent there here, and group nodes all along the left recurrent. So this is actually done at a 2x speed. So that's why it looks a little bit, the video is edited at 2x speed. So you can see the left recurrent all along the paratracheal, retract the trachea, and then the anastomosis. So what I generally do is use a posterior stapled anastomosis, and the anterior layer is sutured using interrupted sutures. So this is how the anastomosis at the end looks like. And then if pleura is there, it can be, the whole pleura can be covered. So now the important, as Shubham Jain had rightly mentioned, whether you should do the en bloc resection or not, I see no advantage, and evidence also does not show any involvement unless and until the esophagus and the thoracic duct are involved. En bloc resection has not added any advantage to the, in terms of outcomes, in terms of survival. Esophagus vein most of them prefer not to clip the esophagus because to preserve the blood supply to the tracheobronchial tree, which is why the bronchial artery can be preserved. Yes, if you can do so, but I do just for the ease of lymph node dissection, and it's a choice that it's very difficult to produce evidence whether to do pyloromyotomy or not. It does not make a difference whether you do a pyloromyotomy, but we routinely prefer to do an internal dilatation. But the evidence shows whether you do or you do not do does not have an impact on gastric. So if there are any questions, I would be happy to take them, Shubham.
There are none at this point in time.
Any tips for salvage esophagectomy? So this was a planned esophagectomy, a planned case, for example, if you discuss, but somebody who received definitive CTRT and following that has a residual disease. Then for that patient, any tips?
Yeah. For post concurrent chemoradiotherapy, I think the only problem is the radiation dose is a lot here. We have operated a few cases post concurrent chemoradiotherapy. I would say that keep your energy sources to the limited, as limited because as you denude the entire tracheobronchial tree, the most common complication that we have seen is delayed fistulas, either with the mediastinum or the stomach. So these are the only group of patients wherein we commonly tend to see, what lessons we have learned is to keep energy sources to the minimum. Try and keep energy sources. A sharp dissection there probably would be better, but it bleeds a lot. If there's any residual disease, yes, surgery is the only choice that they have in these group of patients.
So Prashant, let me make it very simple. Like in colon, because see, what I want to get from you is how is it different from other organs? When we do growth in the cecum, we don't do a total colectomy. Why do we need to do a total esophagectomy? Why can't you just get a segment out?
Exactly. Yeah. So so the most important here, as I said, is the first slide in the beginning is the lymph node, the patterns of lymph node spread. So the most important is the extent of lymph node spread because it happens longitudinally also along the submucosal region. So that was my first slide of the presentation. So that is the reason for doing removing the entire esophagus. And as you see, margins are very important. The recurrence rates are higher with lesser margins in squamous cell carcinoma. The best ideal margin would be 10 centimeters of esophagus in its anatomical position, not the contracted one. So mind you, 10 centimeters. So that is why it is important when you do your endoscopy, it is important to map your disease correctly, which will actually help you from the cricopharynx, because that is where about 1 to 2 centimeters below your cricopharynx, you would be doing your anastomosis. So that is the reason why you actually do not do segmental resections in esophagus. For adenocarcinomas, yes, up to 5 centimeters of esophageal margin is a good margin, and the stomach can be similar in terms of stomach where you get a distal 2 to 3 centimeters of margin on this.
All right. So if it's a G junction, which comes out to be a squamous carcinoma, how would you approach it? I mean, would your approach will be more, it does not matter whether it's a adeno or a squamous, or will it be different?
Yeah. So yes, it will. If it does matter whether it is adeno or squamous. If it's a lower third, would matter from I would basically put it as Sieverts 1, 2, and 3. I know that now you treat it like either esophagus or stomach, so I will divide it like that. If it is an esophagus, I would give neoadjuvant chemoradiotherapy for both squamous as well as adenocarcinomas. But if it is more onto the stomach, adenocarcinoma, I would prefer to give neoadjuvant chemotherapy. There's no debate. It's an institutional policy. So I would like to, we have started giving FLOT for all these group of patients. So I would give neoadjuvant chemotherapy and then take up the patient if the lesion is more towards the stomach.
Okay, great. Would you apply the Sieverts in case of a squamous also?
No, it's always neoadjuvant chemoradiotherapy Yeah, it's more or less like esophageal. It's always more or less like to be treated like esophageal, even though it is Sieverts 2. Unlikely that you would get a squamous in Sieverts 3. So,
Shubham, there are some questions on the chat. You want to take? You want to put them to? Okay.
yeah,
Yes.
I think
I'll take them. So the first is request you to weigh in on PAND in lower third G junction adenocarcinoma with some post chemo response at the nodes.
para-aortic lymph node dissection as such, even in stomach, has not shown any advantage, and in esophagus is to be considered as M1. So I wouldn't go on to do a dealing with para-aortic lymph node PAND routinely for any of these cases. So unless you offer surgery, if you plan to offer surgery considering the excellent general condition of the patient, yeah, but routine para-aortic lymph node dissection, definitely not. I treat them as M1 patients.
So those para-aortic would actually need to be proven even before starting your neoadjuvant therapy, whether it's going the intent of treatment, and EUS is a good modality to FNA those nodes because we want to sample those.
Exactly. I completely agree.
Okay. So the next question is, how do you manage squamous cell carcinoma of G junction cardia and involving fundus? I think this has been discussed. The subsequent question is related to lymph node dissection. Why is the right side mediastinal lymph node dissection suprazygous part prioritized more than the left in the classification, like in the definition of extended versus total two field?
Yeah, so that, as I said, we actually, the new definition say it's only total mediastinum where you combine both the right as well as the left together. So why is it more prioritized? And the AP window group are the nodes which are quite important. So if you see whether the nodes along the left recurrent, along the right recurrent, the nodes along the right recurrent are more commonly involved when compared to the nodes along the left recurrent, barring apart the AP window nodes. So probably that is the reason why the extended versus two field definitions were taken into consideration, to the best of my knowledge.
Okay.
Yeah, value of extended mediastinal lymph node dissections in who receive neoadjuvant chemoradiotherapy. I think the evidence is not yet out in terms of whether you should go ahead and do an extended lymph node dissection in group of patients receiving neoadjuvant chemoradiotherapy. But as of now, till evidence exists or evidence prevails, it is better to always do, because you can never go back and later.
Okay. And lastly, your experience with gastric conduit necrosis and how do you manage it?
Yeah, fortunately, only one case. So you take down the gastric conduit. I think gastric conduit is one of the most devastating complications. You pray that it doesn't happen in your life, and I also pray that it doesn't happen in anyone's life. Take down the conduit and let the patient do an esophagostomy, feeding gastrostomy. Let the patient settle down, come out of it, and then use colon as your backup plan. Either use a right colon or a left colon. That would depending upon your expertise and center.
Okay. Any experience with tracheal injuries during a transhiatal or a transthoracic procedure, and how do you manage those? Yeah,
transthoracic, I think, is easier to answer because you have the entire vision on field. Suture them, and primary interrupted suture would definitely help. We've had one such case wherein the left bronchus was injured, and we sutured the left bronchus. Luckily, nothing happened to the patient, but identify them and suture them and repair them at that position, I think, would be the best. If inadvertently during transhiatal, yes, convert it into a transthoracic and then open a thoracotomy or a VATS and then try and repair it at the same. But if you want to interpose anything or not, I think just a pleura or a pericardium would be sufficient in a primary setting, but be careful that post-neoadjuvant chemoradiotherapy, if it's a mid-third where the doses to the trachea or the tracheobronchial tree would have received close to what the esophagus has received. And if it is a definitive concurrent chemoradiotherapy, yeah, please use some flap between the two. Otherwise, you're going to get into trouble.
So do you have any preference if you are operating a middle third vis-a-vis a lower third with regards to intubation for a double lumen or a single lumen?
Yeah, I always use a double lumen tube. If it is for, it depends on what position you are doing. I didn't cover that, I'm sorry. So you could actually do it in lateral position or a prone or a semi-prone approach, depending on what you're comfortable with. If you're doing a prone position, definitely you don't need a double lumen tube. But actually, you can just get away with minimal invasive. If you're doing it, you can just get away with pneumo and still get the same isolation. But if you're doing lateral position, definitely you would need some kind of isolation. You could use a double lumen tube or a blocker, whichever is comfortable. I almost always prefer a left DLT. But the only problem with DLT, with the double lumen left DLT, is when you're doing the iotopulmonary window and the left recurrent, it is very difficult sometimes because you'll have to retracting the tracheobronchial, especially the left bronchus to do the AP window is a little bit difficult when you're doing it. But otherwise, DLT is my choice.
Okay. Next question is on your experience with bronchial artery preservation and its role in recovery.
Yeah, I think we have discussed this briefly, while whether to preserve the azygos or not. Preserving the bronchial artery alone and taking the azygos may be difficult. So when you take the azygos, almost always the bronchial artery is taken. So I have routinely taken, I would say for the last 30, 40 esophagectomies, we have almost always taken the azygos, and in fact the bronchial artery also could have gone, but the recovery, not much of a difference. I do not know of any evidence which shows whether you should preserve or not. We have not had any problems with, but theoretically, yes. The ciliary drainage will be better if you preserve the bronchial artery. Theoretically, absolutely fine that the ciliary movement and probably post-operative thing will be better. But with minimal invasive, I'm not sure whether it would really translate into more morbidity if you take the azygos and the bronchial.
And what is your post-op rehabilitation schedule like for patients?
Yeah, so almost we follow the ERAS protocol. We try and keep fluids as minimal as possible during intraoperative, which I think is very important in any thoracic surgery. And the DVT profile access before and as well as the post-op, and try and get the patient out of bed as soon as possible. The preoperative rehabilitation starts when at diagnosis, when the patient receives starts neoadjuvant chemotherapy or prior to neoadjuvant chemotherapy, with terms of simple exercises like breathing exercises, just asking the patient, motivating the patient to go for a walk for at least half an hour daily, and an incentive spirometry. So when the patient comes in for surgery, he is already well versed with the equipment. He's already well versed with the incentive spirometer, and try get him out of bed. Chest physiotherapy is what is the regular post-operative rehabilitation. And try and start, feeds is one thing which I am a little bit, I know people start feeds, but with the ERAS protocol, we have started oral SIPs as early as day 2. We have not found, luckily, we have not found an increase in the leak rates, but yeah, we'll be able to give you the results soon.
Another question was on pyloric drainage procedures, but I think we've covered that. One more question that has come up now is your port placements for the lateral and the prone esophagectomies that you do.
Okay, I do most of my esophagectomies in semi-prone position. We have stopped doing in lateral position, but I can still discuss the port positions. So the camera port is generally in the mid-axillary line, as low as possible in the 9th intercostal space, and then just draw a V or a U, whatever you call it, 2 posterior, 2 anterior. 3rd, 5th intercostal space, 2 centimeters posterior to posterior axillary line, 2 centimeters anterior to anterior axillary line, and then 2 intercostal spaces below in the 5th or 6th intercostal space. So that would be the standard port positioning for and the simplest port position, which I think, which we have all learned from TMH, Dr. Pramesh. So the standard port position for a lateral esophagectomy, but after moving out, we have switched on to either prone or semi-prone, which I feel is more comfortable. That's only because with a semi-prone, you could actually do away with 1 camera person, because you need only 3 ports. So in the dorsolateral prone, Three ports are placed in the 3, 5th, and 7th intercostal space. Third intercostal space is in the posterior axillary line. 5th intercostal space is the camera port in the mid axillary line. And the 7th or the 8th intercostal space in the anterior axillary line. So these are the 3 ports which we place. And in case if you're not able to get out, you also place another, the 5th or 6th intercostal, 2 centimeters below the tip of the scapula on the line below, exactly below. That will be helpful for a 5 mm port to give you some retraction or attraction, especially when you're doing the AP window group of nodes. And for a prone position, all ports lie between your posterior axillary line and the lateral border of the scapula. Make sure that your ports do not cross the lateral border of scapula, because the moment it goes into the lateral border of scapula, it would be very difficult to do. And you triangulate your ports between 3, 5, and 7 for the prone, with an additional port, as I said, 2 centimeters below the tip of scapula.
And what Prashant mentioned, that we all learned how to do lateral, because that is what our training is. But why Prashant mentioned that we all have moved to prone now, because all of us, including me, Shubham Jain, we have been doing prone only. And to anybody who does lateral, just try prone once and you will realize how much easier it is, and it gives you a similar anatomical view and the similar clearance. Yes, initially it would look like to be a big challenge to put the patient on the prone, and the anesthetist heart is in their mouth actually when they start doing prone. But once they start doing prone, they realize how much stable the patient is, because you don't need so much of single lung ventilation as compared to with lateral one. And also your handling of the lung is much less in case of a prone position as compared to lateral position.
Okay. Another interesting question that cropped up, Dr. Prashant, have you had any experience with COVID patients for esophagectomy?
Yeah, COVID positive, no, definitely not. I wouldn't do a normal surgery if I wouldn't do a lymph node biopsy if it is not urgent. So definitely not esophagus. But yes, the last 2 patients we have operated esophagus who have recovered from COVID. And then we have gone ahead and done esophagectomy in the last 2 patients. But the decision wouldn't influence mine. I'm a proponent. I'm a very strong proponent of transthoracic esophagectomy. And if the lungs are good, yes, there were some additions. I think probably additions are the rule in India. I think, Shubham, have you ever been free that you have not had additions while doing, I think Shubham Jain and Garg, that you never had additions and then you were happy the moment you put in a port in, everything is clean. So, I mean, at least I was not that lucky enough to have an addition-free lungs. So my decision wouldn't change, and I'm a very strong proponent of TT. In fact, when you are experiencing a lot of adhesions, probably THE would likely to cause more damage than TAT. It's a blind procedure. I'm not in for it.
So let me twist the question a little, Prashant. So there is a patient who is a frail lady, and I put a lady because then the distance becomes shorter if you are doing a transhiatal, and you feel that she might not be fit for a tri-modality treatment. She's a squamous, say, lower third. Would you then consider doing a surgical treatment which includes a transhiatal to get off the disease, because that might give you the best chance? The patient is dysphagic already, or would you consider to give just CTRT, knowing that probably she might default on treatment because she will not be able to tolerate the radiation?
Yeah, so I mean, if a patient can tolerate definitive CTRT, patient can tolerate surgery. If patient can tolerate surgery, I mean, it's, if patient can tolerate a transthoracic esophagectomy, I think can tolerate a CTRT. So I would err on the side of doing a transhiatal esophagectomy in this patient rather than exposing her to definitive concurrent chemoradiotherapy arm, which she wouldn't, I think, with the giving the clinical scenario, it would be very difficult. I don't think that she would really tolerate. So if it is amenable low third, unless and until if you see it's too high upper mid third, then there would be some concerns, but yes, but otherwise transhiatal if it is in this patient.
Another twisted question. So you started a patient with neoadjuvant chemoradiotherapy because the patient was fit. but post chemoradiation the lung functions deteriorated. So how would you decide in this? The patient has received just neoadjuvant radiation dose, not a definitive dose. So would you operate, or how would you operate?
No, you mean to say he has not completed the treatment? Complications?
Completed the treatment neoadjuvant, but
Okay.
now the lung function post NECTRT has deteriorated because of radiation pneumonitis or some other thing.
Okay. Okay. Yeah, that's a challenging scenario, Dr. Shubham. So, I mean, if it is because of a pneumonia or something like that, which is temporary, it's okay. You wait, allow the patient to recover. But if it is radiation pneumonitis, which is very uncommon nowadays, yeah, it would be difficult to take up the patient for a transthoracic in that group of scenario. So probably transthoracic esophagectomy, THE, transhiatal would be a choice if the pulmonary functions are not very great. In the sense that if the patient does not, always keep in mind, I always keep in mind that, the PFT should be decent enough so that the patient can at least tolerate a thoracotomy. If you have any untoward incidents and then you know that the patient cannot tolerate and you still want to take up the patient for a transhiatal esophagectomy, I am not sure whether it's a good decision. So if you're doing even a transhiatal, he should be able to, he should be fit. So in bilateral radiation pneumonitis, very poor lung functions, yeah, it's going to be a real challenge. I'm not sure.
And in the post-op period, have you ever had any chance of patient who's not recovered because of bad lungs or radiation-induced pneumonitis post-esophagectomy? Any experience in that?
Luckily, as of now, I mean, I'm very lucky to say that we have not had any patient, because most of these patients, we tend to operate at about 6 to 8 weeks of time. And so they do develop some kind of pneumonitis and they manifest by the time we go for surgery. So if we see some radiation pneumonitis on CT, reading or CT scans are very, very important before surgery. If you see some radiation pneumonitis, I think it's okay to wait for an additional 2 weeks. There is no harm waiting for an additional 2 weeks rather than taking up the patient if you have florid lung changes. I have no experience with patients developing radiation-induced pneumonitis in the post-esophagectomy. I would put it as more likely that it would be post-surgical, either a collapse or a consolidation in the post-surgical period rather than radiation pneumonitis if you do not have these findings in the preoperative scans. I don't have any experience.
Okay.
All right. So those.
So I guess,
yeah.
Shubham, those are all the questions.
Yes. So I think what we have not done is gone purposefully into the complications of esophagectomy, although we covered gastric tube necrosis and we had spoken of pneumonitis, and but we did not touch upon leaks and chyle duct injury. But I think that's something which is more of surgical interest. And the purpose of doing this lecture today was that we wanted all the students, specifically the radiation medical, to realize that the esophageal surgery has basically the three components, and all of them have multiple questions linked to it. So one, as Dr. Prashant has told, is the esophageal resection, which includes the mobilization of the esophagus, which is into the thorax. Now that esophageal mobilization can be done by open VATS, which is the video assisted thoracoscopic, and the robotic surgery. And this is what defines the survival of the patient, because at this point in time you remove all the lymph nodes also, and you have to choose the type of lymph node dissection that you do, as Dr. Prashant said. Now what you need to do is to recreate that feeding tube. Once you remove the whole of the esophagus, we talked about why we need to remove the whole of the esophagus and not just a segment of it. You have to use a substitute to fill up that space between your pharynx to your stomach. Okay, and that are the three possibilities which again Dr. Prashant mentioned, and of which the preferred one is this. Now that stomach, again, once you do abdominal surgery, you can do it by an open approach, you can do a laparoscopic approach, and you can do a robotic approach. Now, once you do that, how do you get it back into the thorax? Again, there are those three approaches that we talked about. That is, you can get it through the posterior mediastinum, you can get it substernally, you can get it subcutaneously, which again Dr. Prashant mentioned why we get it through the posterior mediastinum. And once it is inside, now you have to do anastomosis, which is leak proof. Okay, now that anastomosis again can be a hand sewn, it can be stapled, the stapled can be a linear stapler, circular stapler. So these are all the intricacies which go into the surgical management of esophagus, and that is why it's very important that an experienced team, experienced center, and a composite team does it. So we are very thankful to Prashant to do it, and do it at actually a short notice. We didn't give him much time to prepare this lecture, but the professional that he is, he did it with such panache that we couldn't have asked for anything better. Thank you so much, Dr. Prashant. We next week we will move on to the new adjuvant part of it. A lot of us were talking about NACT, NACT-RT, but we want to actually address all of us accept that there has to be some form of neoadjuvant treatment, and there is building up of consensus about the type of neoadjuvant treatment that is possible. But still, we wanted to get both the views available, that which is the better one and which one you should adopt. And for that, we have, instead of doing a more of a didactic lecture, we thought we'll have a sort of a debate where one of the speakers is going to talk about NACT and the other will be speaking about NACT-RT. And for NACT, we will be having Dr. Sanjay Sharma from Bombay, who's a very passionate speaker, and he does a lot of esophagus and he has unrivaled data. For doing NACT-RT, we are still in touch with a couple of radiation oncologists, but let us see who bites the bullet. But I'm sure it's going to be a riveting class, and it's going to be a sort of a debate which we have been trying to do for a long time. I hope we'll be able to pull it through. So thank you so much. Dr. Geeta, are you still around? Any last words?
Yes, I'm there. Again, another brilliant class. And I think, the thing is, in our journey to, capture the big things, we often forget that the small things, the small nuances of every procedure is very, very important. And I think Dr. Prashant did a good job of bringing those bits out. And and we had a very good attendance. In fact, if you were to look at the number of people who logged in, some logged out, but I think we came to close to 70, 75,
So
and we had till the end, so it was very well appreciated. Yeah. So you've done a great job. Yeah, and I'm sure we'll see more of you. And
Dr. Geeta.
Okay.
I'm sure the person who's going to talk on the neoadjuvant chemo radiation will be as vociferous as the as Dr. Sanjay Sharma, who would not otherwise let you get a word in edgewise. So it'll be a very interesting meeting next week as well. So looking forward to that one. Thank you so much. Thank you. And a very
good night. Good night. Thank you, Prashant. Thank you so much.
Thank you, Shubham. Thank you, Shubham Square. If I can
thank you, Shubham Jain. Yeah.
Okay. Bye.
Bye. Good night. Good night.
Bye. Good night.